Hello everyone, today we are starting a series of educational videos on the PT mini screws. This series is primarily aimed at clinical practitioners, focusing on the clinical application and use of mini screws. Implants are a valuable tool, but many doctors may hesitate due to unfamiliarity with the insertion technique for mini screws. So today, we will provide an overview of how to insert PT mini screws. Before inserting the PT mini screws, we need to prepare several tools. First is the mini screw itself, which comes in various models. The selection of the screw type typically depends on the structural morphology of the alveolar bone. For the anterior region, the distance between the roots is generally shorter, meaning the interroot spacing is narrow. Therefore, we opt for a thinner mini screw, typically choosing one with a diameter of 1.4 mm or 1.5 mm and a length between 6 mm and 8 mm. In the posterior region, the distance between the roots is larger, allowing for greater insertion space. So, a slightly thicker mini screw is chosen, typically with a diameter of 1.6 mm and a length between 8 mm and 10 mm. In other situations, such as when inserting into the zygomatic alveolar crest of the maxilla or the external oblique ridge of the mandible, we may select a thicker mini screw to 0.0 mm * 10 mm. Regarding the tools used during the insertion of mini screws, the first is the screwdriver handle. This is a standard handle. For the buckle side, we use both the handle and the screwdriver shaft in combination to form a screwdriver tool. Then, we select the appropriate mini screw for insertion. Next, I will discuss each side one by one. Clinically, the most commonly used side is between the roots, specifically the mini screw inserted between the maxillary fifth and sixth teeth. Typically, the height is selected based on the archway plane as a reference, approximately 8 to 11 mm above it. This is because, in this area, according to anatomical studies, the distance between the roots of the fifth and sixth teeth is about 3 mm, providing sufficient space for insertion. If the screw is placed too low, the distance between the roots decreases as you move closer to the occlusal plane. Usually, we choose a height of 8 to 10 mm above the archway plane. This region offers enough interroot space, and it is located near the mucogingival junction. If placed too high, it enters the phrygian gingiva, which is more prone to infection. Therefore, we generally select a height 8 to 10 mm above the archway plane. The second consideration is the lateral positioning. Generally, for the area between the maxillary fifth and sixth teeth, we use a probe to locate the area above the central contact point between the fifth and sixth teeth, creating a slight indentation. After making the indentation, a marking point is made 8 to 10 mm above it. If using a periodontal probe, which is calibrated, it helps in accurate marking. Based on this, we can position the marking point slightly closer to the midline, about 0.5 to 1 mm closer to the maxillary fifth tooth. This area has sufficient bone thickness, the distance between the root surface and the buccal bone, enhancing the safety of the screw insertion. Additionally, as we often move backward, the increased bone thickness reduces the risk of contacting the tooth roots. After marking, a probe can be used to create a mark clinically. In our model demonstration, we'll use a marker to create the mark. Once the marking point is made, select the appropriate mini screw. Generally, a 1.6 * 8 mm screw is sufficient for this area. After locating the mucogingival junction and the marking point, prepare the PT 1.6 * 8 mm mini screw, which is commonly used between the maxillary fifth and sixth teeth. In clinical practice, it's crucial to strictly follow the protocol for mini screw insertion. Today, we are providing a general demonstration. There are two insertion techniques: direct self-drilling and assisted drilling. For this case, we are using self-drilling, which requires the insertion angle to be approximately 20 to 30 degrees relative to the tooth's long axis. When inserting, there are two approaches. The first involves initially drilling vertically to penetrate 1 to 2 mm, just enough to break through the cortical bone. After this, withdraw the drill slightly, change the angle to approximately 20 to 30 degrees relative to the tooth's long axis, and gradually insert the screw in a diagonal manner. The key here is not speed, but stability, as drilling too quickly generates heat between the screw and cortical bone, which could compromise the bone integrity and reduce the screw's overall stability. Another point in clinical practice, when inserting on the left side, ensure the left lip is retracted adequately. Otherwise, the lip may push against the screwdriver, causing it to move mesially, which in turn could cause the screw to insert distally. Thus, it's essential to consider the impact of soft tissue pressure. Additionally, during mini screw insertion, pause to check the screw's angle with a dental mirror to ensure it remains at the correct angle and hasn't shifted distally or mesially. As you continue insertion, slow down the speed because tightening the screw becomes more critical towards the end. Improper tightening could compromise the continuity of the cortical bone, which is crucial for the mechanical retention of the screw, relying primarily on the outermost 1 mm or so of cortical bone thickness for secure fixation. This is the diagonal insertion technique. In some cases, if the bone morphology is such that it varies, for example, either straight up and down or S-shaped, a diagonal insertion may not be feasible. The bone becomes thinner as you move upward, so inserting the screw at an angle may result in the tip not being adequately supported by bone. In such cases, you might need to insert the screw at an 80 to 90 degree angle relative to the tooth's axis. This method has the advantage of providing greater stability, similar to driving a nail vertically into a wall for better hold. However, the disadvantage is that if the interior distance is insufficient, there's a higher risk of damaging the tooth roots. Nevertheless, diagonal insertion is generally safer overall.